So, members, we have formed a quorum, and I'd like to thank members for attending this meeting. Let me call the meeting to order. Shall we invite the Permanent Secretary and Mr. Sun to come in? I'd like to remind members that about the progress of this subcommittee meeting. On the 6th, we met with the deputations who have given us their views. And at the end of last year, it's not the 6th, rather it's December. Last year, the government has come up with the latest proposal. And in the last meeting, that was held in September 2014, we raised certain questions. And the government has replied to us in December, and we haven't held a meeting to discuss the reply. So, for this meeting, item 1, there are 2 papers from the administration. One is response to issues raised at the meeting on the 12th of September 2014, and the other one is the response to issues raised at the meeting on the 6th of February. Perhaps can we ask the PS to take us through these 2 papers first? Thank you, Chairman. We started a public consultation on the 15th of December, and the consultation period will end on the 16th this month. And earlier, we took you through this proposal, and on the 6th, we attended the open hearing. And in the past several months, we have heard many views. So I would like to take this opportunity to make certain responses to the views expressed. Standard or minimum requirements of VHIS, that was aimed at resolving the many diversified policies in the market. So we want to ensure that there is a basic protection for the insured. I must stress that minimum requirements mean that not that the government that will draw up a template for policies, and it will be the government or the insurer to sell the policies. What we are doing is we are following examples from other markets. We are just drawing up minimum requirements to protect basic interests of consumers in the indemnity hospital insurance products. And for all such products sold in Hong Kong must meet with such basic requirements or even go beyond those. And as long as these minimum requirements are met, the public are still free to choose the products which suit their needs. Our aim is to ensure that the insured and the consumers can have real choices. For example, they can make meaningful comparisons among different policies, how their protection is, and also if the insured has taken out a policy which offers low level of protection, but then several years down the road their economic condition improves, but then their health deteriorates, whether they can buy a policy which offers better protection. So these are the issues that we want to tackle this time. We understand that people are very concerned about the impact of these minimum requirements on premium. According to our estimates, plans meet with minimum requirements will come in a price of an average $3,600. That's an average figure, but of course it may vary from policy to policy. And the average on the market now is something different. And actually, it is around $3,300. So it's a difference of 9%. The aim of VHIS is to formulate the minimum requirements to give basic protection to the insured and to enhance the transparency of hospital fees and boost competition in the market. In fact, we have noted that new products launched on the market recently have incorporated our proposed minimum requirements. For example, guaranteed renewal and also undertaking coverage of cancer treatments, etc. And the premium is more or less at the level of $3,600. So we are seeing such products in the market now. And there have been suggestions that the tax reduction proposed may not be able to attract more people to join in the insurance market. We are suggesting that apart from the insured, the dependents of the insured can also benefit from the tax reduction, so the whole family can benefit. We believe that this may be attractive to the middle-income families. We understand that young people who may not have to pay a tax may not benefit from such tax reduction benefits. But the VHIS is also targeting them. I think it brings some benefits as well. For example, for guarantee renewal without re-underwriting, for this feature, if young people take out insurance at an early age, then they can benefit or be covered throughout their entire life, and if their health gets worse in the future, they can still enjoy the benefits and they don't have to pay an extra loading. I must emphasize that for this $3,600, this is just an average figure, and it varies from age to age. So in our consultation document, page 58, we have listed the premiums for the different age bands. For example, 20 to 24, the annual premium is only $1,450, and for those age 30 is an annual premium of $2,200 only. We understand that people are concerned that about the manpower, whether we can cope with the future healthcare needs. And actually later on in the day, in the second agenda item, we will go into the details of manpower planning. I would like to point out here that we are striving hard to increase manpower supply, including increasing the number of doctors and nurses in the hospital authority, and we would try to hire part-time doctors. We would offer more degree places for doctors, nurses, and allied health professionals. And the Medical Council has also improved the licensing exams, and they are now offering the exams twice a year instead of once a year. And they are also considering relaxing the internship arrangements so that more overseas doctors can practice in Hong Kong. So lastly, I would like to mention that after the consultation period, we will compile and analyze the views collected, and we will be coming up with a conclusion of the consultation exercise, and we will set the way forward as well. Members, questions? 5 minutes each, please. The first one, Dr. Kwok Ka-ki. Chairman, Permanent Secretary, there have been many issues raised in relation to VHIS. Last time, many professional bodies and members of the public came to express their views. I've mentioned many times about the fairness of the proposed scheme. High-risk pool. Well, we're talking about an amount of $30,000 for retirees. We hope that retirees can join the scheme, and retirees may join the high-risk pool. And we are talking about a premium of $30,000, so only a handful of people can join. You're talking about an investment injection of $10 billion, and you are using it on those aged 65 or above and they're relatively well off. Is this a fair arrangement? We know that medical resources are limited. We want to treat everyone alike, those aged 65 or above. So that's point number one. Second point, in the overall design of this scheme, with regard to the premium and the administrative costs, there is no guarantee that they should be at a fixed level. Well, in the last week, people from the insurers associations relayed their difficulties to us. They said that, well, they would be shifting the burden onto the consumers. Now, the government has come up with many demands, requirements like guaranteed renewal, guaranteed acceptance, and so on. We envisage that premium is bound to rise and not drop. Thirdly, the government says that policyholders, many are not using private hospitals, so we want to increase that figure. Now, I believe that premium is going to rise in the future. You're talking about $3,500. That was a figure 3 years ago. You drew up 3 years ago. And if we are going to implement the scheme, I don't know how higher it will get. This is going to be a black hole because the premium is going to rise with people aging. And the government is very courageous, so to speak, this time. Many people have raised objections, and you're still pressing ahead with your proposal. So I'm very worried. There are so many issues that are left unresolved, and the government said that it will insist on going forward. Ultimately, two groups of people are going to suffer. Of course, the private hospitals are going to thank you because a lot more customers will use their services. But for members of the public, the taxpayers, we are asked to pay. And also, for those who don't have the means, what is going to happen to them? And also, I'm very worried that many people will be attracted to join the scheme, and ultimately they found that they are paying a higher and higher premium, and the premium is going to rise continuously. I think there is a great moral risk here. I believe that the government is attracting people to join a so-called bottomless pit. Is it that the government will insist on pressing ahead even despite all the objections we raised? Okay, I will take your questions one by one. First is about the high-risk pool. 200% of the standard premium. So anyone with 2 times the risk is allowed to join the high-risk pool. We are trying to strike a balance here. If the risk is lower, then the premium will get lower. But then, so the $40 billion we propose is something that we want to spend, aiming to strike a balance. So we would accept people with more than double the risk, and in the next several decades, then we're talking about a spending of $40 billion. So if the risk is going to be lowered, then the amount we may drop to a lower amount. So we just want to solicit the public's views on whether we should establish a high-risk pool in principle. That means anyone who would like to join an insurance scheme can take out insurance. That's what's happening in overseas jurisdictions. And actually, we can follow some overseas jurisdictions in legislating on this, but then we don't want to go along that route because we don't want to ask the insurance sector to shoulder higher risk.
We also want to respond to the need to take out insurance. Say, for example, I have a heart disease or I have diabetes, I'm in my 30s, I cannot take out any insurance. Of course, you can have the so-called exclusions. But this cannot be excluded. So these people have to be considered. Our proposal is this. If you want to accept everybody, whether they are in their 20s or 30s, they have, say, inherent diseases or diabetes or heart disease, and then we force the insurance companies to take on these clients, and then they pass on the risk to us. We take over the risk. The government takes the responsibility. And now, of course, that will make loss because of high risk. The premium is not proportional to the risk. Say the risk is 10 times, then the premium will also be 10 times normal. But we take on the risk. You can say it's 100% more. And then people can take out insurance, say, by $6,000 if the average is $3,000. But we need to balance the risk. Should we go down the road of a high-risk pool, whoever can be accepted, whatever illness he has. And then we have to make a decision on the risk. Say, for example, it would be the 200% or 100% more. Say with 100% more, then it will cost about, say, $8 or $9 billion. So let us look at this part. This is about the high-risk pool and also the premium. And that's the relationship between risk and premium. The second question is about the increase in premium. This is not a compulsory insurance scheme. We don't force any people to take out any insurance cover. It's just like the present situation. If you want to buy it, you can buy. They don't tell you what they will charge next year or the year after next. Premium will continue to increase. The difference with the present situation is about the products. This morning I looked at some of the products in respect of health insurance. I find it very difficult to compare because they are very different. Unlike, say, third-party insurance. And we have to consider whether we want to know whether chemotherapy or ambulatory treatment or things like that, or visits by specialist doctors. There are many items in the package. We want to have a basic package first. Say, for example, room and board for a private hospital, say $650 per day, and the policy should cover 180 days. We want to arrive at an agreement with the trade. You're a doctor, you know this. Insurance can never be adequate. We just want to set the basic package. If we don't do anything, the premium will continue to rise, and you don't know what the future level will be. We now propose to do something. People may worry that premium will shoot up. Say the terms may become better. Say, even if chemotherapy is included, they only cover up to $50,000. You know, as a doctor, you know whether it's adequate or not. We do not insist, but shouldn't the basic package be $150,000? That may have an impact on the premium. If we look at it objectively, this morning I look at a whole range of products by new policies by large insurance companies. They have proposed terms, say ambulatory operation, endoscopy, and things like that. Some may cover 180 days of doctor visits. Some may cover 60 days. If you look at the policy, the average premium is about $3,000. The premium is similar to our proposal. And that's why we recognize or we accept the estimate by the consultants. Well, the figures mentioned by the consultant was about 2 years ago. Even today, there are 3,000. The premium is about, on average, $3,000. when they are competing for the markets, they are charging at about that level. So we are confident that the premium will be reasonable. Let me stress that $3,000 is an average. Many will be lower than that, many will be more than that. We're talking about those in their 20s. They are paying about $1,000, $2,000. In their 30s, about $2,000, $3,000. In their 50s, 60s, maybe $5,000, $6,000. As for private hospitals, that's about the fact. If there are more policyholders, they will make use of the private hospitals more frequently. With more usage of private hospitals, the insurance companies will have to honor more claims. We hope that more can make use of the private sector hospitals. The trend is that the claim ratio is higher. In the past 2 years, we saw that the claim ratio was about 57%. The latest is 69%. To a great extent, that is a result of improved terms in the policies, and there are more people taking out insurance. But with that, they still have quite a broad margin. The volume can also help. The claim ratio is higher, but we have not seen substantial increase in premium. As for the final point, will the administration go it alone? Well, I think the answer is obvious. We cannot bypass the Legislative Council. We listen to the view of the Council. We listen to the view of the insurance industry. We also consider public opinions arising from the consultation. We will consolidate the ideas and try to find a balance. We'll come back to you on the way forward. We will not go it alone. Our objective is to give greater protection to the insured. I'd like to remind members that 5 minutes refer to the time you speak, so you don't need to make full use of 5 minutes. Well, I still have some tens of seconds left. I think there is a crucial question here. You say you don't force people to take out any insurance, but you have given an incentive to taking out insurance. So don't you have the moral responsibility? Say you ask people to buy insurance, you put up advertisements, you provide tax concession, and then afterwards, when the premium increases, you wash your hands. Is it not unfair? Now, say for 2 times additional premium, that caused the premium will be about $30,000. Now, if you say from $10,000 to $30,000, they will not be in your premium high-risk pool. They will have to pay for themselves. As long as the person is below the line, they will have to pay for their own premium. They will not be subsidized. I prefer you draw the line lower. Say if they have chronic illness, even if there is an additional 50% premium, they still have to be cared for. If they're not cared for, they will have to pay very high premium. Everybody knows why. They are high-risk people. The government will not subsidize them. Now, the only thing you can prevent the escalation premium is that you provide more support or protection. As for the moral risk, we encourage people to buy medical insurance, health insurance. I agree with the moral risk you mentioned. That's why we have been quite late in making the proposal. Now, we encourage people to take out insurance, and then we step up regulation. And we cannot regulate each and every insurance company. Then, therefore, we set out the basic protection, which everybody thinks is reasonable. This is the minimum requirement. That makes us easy with that moral hazard. Now, if he takes out insurance in which there is no guaranteed renewal, then after 5 years he is rejected. Then he comes to the government and asks why. That's the moral hazard. We need to find a suitable balance, and while encouraging people to take insurance, we need also to balance it against the moral hazards. Now, medical insurance is really a very complicated matter. Now, when you lower the line or the threshold, then the community will have take up a higher cost. And to what extent is that acceptable? Do you have the information in the document say if the high risk pool is reduced from 3 times to 2 times, to 3 times the standard, 3 times the standard or 2 times the standard? Now, in fact, you ask for different age groups. We put it in. We need to give you a separate calculation. Say 100% more than the standard premium, or 200% more. Yes. I intend to follow this issue up. With regard to the high-risk pool, the age is 40 for drawing the line. What is your projection? Can you provide us with more information? How big is the sum? The more young people taking out insurance will help to share out the risk. Now you want to use the tax as an encouragement. How can you encourage young people below the age of 30 to take out insurance? Are there any good proposals? Now, the deadline of consultation 16th March. The Secretary said that he would consolidate the opinions and then report to us. You want to legislate in the year 2015-16. Would there be new proposals after you consolidate the ideas? And will you embark on, and then you will go ahead to make your proposal instead of doing another round of consultation? Is it the case? As for making a choice at the age of 40, will you consider not just limiting it to 1 year? And what will that, the implication on the whole scheme? First, on the age of 40, we can provide the numbers or calculations. Now, when we draw a line at different ages, then the burden on the high-risk pool will be different. Page 75. At the age 45, 4.6 billion. 50, 5.3 billion. 55, 64. And then 65, 11.9 billion. That's based on 200% risk. 200% additional risk. As for drawing line at 40, if you take out insurance before 40, you are not affected. If you wait to take insurance at age 40 or beyond 40, that will be different. If we draw a line at 50, then people will only wait until the age of 50. In Hong Kong, we have a parallel system in both the private sector and public sector system. And when people become old, there will be more chronic illnesses. Now, we need the working young people and middle-aged people to take our insurance. They can have a choice. They can make use of the private hospital system. They don't need to wait for 3 months or 6 months for a public sector hospital.
Now, so that's why we want to attract the young people and the middle income groups to join this scheme. And for young people, they normally suffer from, say, acute illnesses, and the utilization of hospital services will be very different from the elderly people who are usually chronically ill patients. So that's why we draw the line at 40. One of the requirements is guaranteed renewal. So if you take out insurance at 20, 30, or 38, and no matter how many claims you have made, you can still get your policy renewed, and the insurance company can't charge you a higher premium. So that's why we draw the line at age 40. So this age has everything also to do with the whole system, the design of the whole system, and not just the premium. Now, if we draw the line at 50, well, everyone will take over insurance at, say, 49, and then when they have paid premium for a couple of years, and they will start making claims. So if you take an insurance, say, at 20 or 30, then, well, claims will start to be made, say, 20, 30 years down the line. So the age has everything also to do with the shouldering of risks. And we encourage young people who are still fit and healthy to take out insurance, and then they would make claims only after a long period after they have taken out the insurance. So that will make the system sustainable. I would also like to respond to moral hazard, the point made by the member. We want to have tax incentives. We also want to make sure that proper regulation is in place to ensure that the insured can get value for money policies. Now, we have to still spend time if we want to study legislation, if we want to do that. And after the consultation period, we will collate the views, and then we will report to the subcommittee, and we will also share with you our direction ahead. We will only go ahead after we've forged a consensus. So I think we still have time to do it. Any follow-up? You do have time. Next one, Mr. Yu Si-wing. Thank you, Chairman. I think the VHIS is a good proposal. Well, there, of course, are many problems in implementation. The government aims to make sure that those who can't afford insurance can now take out insurance, and young people can join insurance schemes at an earlier age. We talked about guaranteed renewal, and young people may get insured by their employers. Sometimes, say, if a person takes out insurance at the age of 40, and then when I'm still 60, I'm still fit and physically well, and I will continue to with my policy, because without that, then there will not be a protection. And then, say, at the age of 70, I'll become penniless. And then, but then I can't afford to continue with the policy. But then I've paid a premium for some 30 years. And then I have to seek service or seek assistance from a public hospital. So that is very undesirable for this 70-year-old person. So can you consider something like this? At the high-risk pool, then there is some protection for such types of people, that you will come up with a formula to help this group of people, to subsidize this group of people for a certain number of years, so that those who have paid premium for several decades can be helped on the day when they can no longer afford to pay up their premium. Several years back, when we did consultation, there were similar views expressed. People suggested a saving element. It's just like a type of life insurance policy. And we have to strike a balance in terms of the premium. If you have a saving element, you may have to pay more. 1,250, 15 to 19,500, and 30 to 42,200 dollars. So the premium will rise with your rise in age, increase in age. So the general response at that time that they would not like a saving element in the scheme. Well, people would prefer to save up on their own instead of putting their saving into an insurance scheme. As to the case you mentioned that people have paid premium for several decades and they can't afford then to pay the premium. Well, if you don't make a claim for several decades, and that's a good thing. Now we have both a parallel system with private and public healthcare systems. In the U.S., there is guaranteed protection for persons throughout his entire life. And the people would be spending a lot of medical expenditure during their latter years in life. And the concept of the insurance is that the majority of people don't make claims and only a minority of people will make claims. And the claims are actually funded by the majority of people who don't make claims. And, well, a person who makes a claim is actually the claim is being funded by the majority who don't make the claims. So let's not confuse the concept of savings and insurance. It's a premium, which like the travel insurance or auto insurance, you don't want to make claims. And the premium just, has been paid out. You never get any return. And anyway, when we did the consultation back then, people were not interested in incorporating a saving element into the insurance scheme. I'm not talking about a saving element. When you age, you can try to apply for some form of elderly subsidy. So that's different from saving. Now, when a person gets old for various reasons, he may not have an income. And perhaps several years down later, he will get some income. And there are all sorts of family reasons why people can't afford to pay premiums anymore. Now, what I'm suggesting that you have a high-risk pool, and that incorporates a concept of subsidy. And well, I think you can consider my suggestion. Say if you start paying premiums at the age of 20, 40, and then when you reach 70 and you can't afford to pay the premium and you get nothing. And if you don't do anything towards this group of people, I don't think you are not taking proper care of them. Can we add a function to the high-risk pool? So in the case of the person that I mentioned, he can, through going through some form of procedures, can apply for funding to pay a premium, say for another 1 to 2 years. So that's very different from saving. Your aim is to encourage more people to take out insurance, and that's also why you want to set up a high-risk pool. So can you incorporate this other incentive into the high-risk pool? I understand Mr. Yu's suggestion that can be considered as an opinion in the consultation exercise. Mr. Yu, you talk about paying premium for an extra 1 to 2 years. What do you mean by that? Say, if the person has paid a premium for 30 years, and maybe if he gets penniless, can't afford to pay premium, then there is a formula to calculate how he will be funded in terms of paying up a premium. For example, if he has paid a premium for 20 years, there is a formula for calculating the period in which the government will pay for him. So that will make people happier. I would be very unhappy if I have paid a premium for several decades and at the end of the day I get nothing in return. Understand. Next, Ms. Alice Mack. And this morning, we announced the results of a survey. We interviewed some trade unions, their members, and actually a lot of the respondents, 60% said that they do not know about the content of this VHI, as nobody knew anything about the 12 minimum requirements. And everybody thinks it's a voluntary scheme, and they will decide whether to take out the insurance or not after the scheme has been launched. And well, they are not aware that once the scheme is launched, then they will not be having the existing policies that they're taking out, those with the lower premium. So a lot of people, after finding out what it's all about, said that they would not take out this VHIS. They are not willing to subscribe to it. So my first question is for the PS is, well, I think it's your scheme or your proposal was presented or put forward on an unopportune time. It's just like the constitution reform package. Would you consider extending the consultation period and do more work? Mr. Soon actually and I went to the district and attended residents' gatherings, and ordinary members of the public are not aware of what it's all about, is because it's too complicated. So can you do more consultation? Would you consider extending the consultation period so that more people can express their views? Can you also enhance your publicity to let people know what the scheme is about? Second, the closer I look at the proposal, I wonder why young people should take out insurance. And a lot of people asked me, why should I be taking out the insurance you propose? Well, you've been upholding the features like guarantee, renewal guarantee, acceptance. But apart from those, what benefits will it bring to them? Especially when they can always go back to the public healthcare system. What is the reason for them to take out private insurance? We've always been saying that the tax incentive proposed is not sufficient. What other means do you have to encourage young people to join, apart from saying that it's guaranteed renewal and so on? What other measures would you consider to encourage young people to take out your proposed insurance?
Now, let me remind you this. When you were young, you take it out, that was standard premium. And when you have got an illness, you will have to pay 3 times the premium. Why do I have to pay some premium for so many years? Why do I have to take out car insurance, employment insurance, and life insurance? That's mandatory. Without insurance, my car cannot run in the streets. As a civil servant, I don't want to lure people into doing something. If it is a good public policy, then we should make people understand this good policy, and then people will do it voluntarily. This is like travel insurance. We don't give monetary incentive to get people into taking out travel insurance. We want people to take out insurance to protect themselves. Now, after we've dealt with this, we'll go back to the issue of moral hazards. We make sure that the products are reasonable, they give reasonable protection, and then we'll go out to do a wide publicity. You're right in pointing out that people don't understand the dozen or so items. If they have got an insurance policy, do they know what's in their policy? Well, if they don't know what's in their policy, then they probably don't know what our proposal is. They have a poor understanding of insurance. In fact, we've done a lot of publicity and communication. This is voluntary, and we have a public and private sector. We have a public sector and a private sector. In terms of health care, we therefore target voluntary insurance, VHIS, at the middle-income group. If they cannot afford, they are not interested. We target at those who can afford. We hope they can understand this insurance concept. They understand the use of insurance. Young people have to know this. Now, for car insurance, if you've claimed once, there will not be any NCB, and loading will also be increased. That is to ask you to reduce risk. I'm not defending the insurance companies. Now, with less, with more care in driving, there will be less accidents, less people hurt. If it is medical insurance, even if you increase loading by 10 times, you cannot cure the person completely, though we have very good doctors here. And we need to educate young people. When you are healthy, you take insurance, the premium is lower, and in the future, when you need medical care, you need you don't need to worry about being rejected next year. Or I think probably the understanding is not adequate. In the 20s, you pay $1,000 per year. Just $1,000 per year. How can that be not affordable? It's hard to sell insurance because people don't know it. People have not used it. If you have used it, then that was already unfortunate. That is unfortunate. When you're ill, you go to the public sector hospital. We hope community understands that we keep investing in public sector health care, but you have to wait. And you cannot choose your doctor. And there are many restrictions. As for young people and those who have a family to care for, if they can afford it, it's better for them to take out insurance so that they can get speedy treatment in the private sector. We need to step up publicity as for extension of the consultation period. Let us look at the responses by the end of the week. Let's look at the responses and the scope and the quantity. We have many focus group meetings to consult the parties concerned, and we are able to understand the sentiments of the community at large. The PS. Now, when you do your consultation, it is more focused. Maybe you think that those union members are not able to afford. It's normal that they don't understand insurance. But the union we consulted, we talked to were the clerical workers' union. And many of them did take out insurance covers. But they don't understand your consultation document. They are policyholders. Now you say there will be more publicity, more education. Maybe you have to work harder. Well, if you say elderly people don't understand, you just leave them as they are. But there are those who have insurance policies and who don't understand the concept of your VHIS. How can you get the support of the citizens? Are you just focusing on some of the target groups and just get them to support you only? It is impossible to get a seminar for 7 million people. Altogether, we need to consult in groups. And in fact, we have several options, and we spelled out that there are certain issues you have to pay attention when you take out medical insurance. Say, for example, you need the renewal provisions, and also major provisions. In some people who have taken out insurance policies don't know the major terms. Do you have these conditions or these requirements in your policy? We need to deal with that because people who don't understand. I think we need to step up publicity. Please do consider extending the consultation period. It seems it's too short. It will come the end. It will be end of next week. The end of consultation period is end of next week. People don't understand the high-risk pool. Now, if you've taken out insurance cover before, you've fallen ill, then you don't belong to the high-risk pool. You need to let people know. Even if I know it, I can speak out on your behalf, but your responsibility is to let people know that. If people don't understand, they cannot support your proposal. They don't know what you are selling. This is just like 40 years. A 40-year-old is the threshold. All right, any follow-up? Next, Dr. Joseph Lee. Mr. Yiu's question is pertinent. Do you have an arrangement, say, that after paying premium for so many years, you don't need to pay further premium in the, say, following years? Say maybe I have been paying the insurance premium for many years, and after I become 70, I claim several times, and then there is a problem with my premium. What sort of insurance is it? Yes, for insurance, life insurance, they do have certain arrangements. Say after contributing your premium for so many years, and you don't need to pay premium in the subsequent years. I don't know whether you can do that for medical insurance. There must be a reason for VHIS. You want to bring people to the private sector, bring patients to the private sector healthcare system. We discuss high-risk pool while you draw a line at age 40. There must be a reason for introducing VHIS. You think the middle-income groups can afford healthcare costs, and therefore they don't need to queue up for the public sector service. I've taken out insurance. I was knocked down by a car. Then I will be sent to a public sector hospital. I will not raise my hand and say I've taken out insurance. Now, if we want the middle-aged groups to have a choice, then you better tell them that this is an arrangement for non-emergency operations. That's a kind of civic education. If you can afford, please do not queue up for public sector service. Please go to the private sector service. But it seems that is not to be said. Now you want, if it is compulsory, then it's different. Say if you earn so much money, then you have to take out insurance. If it is non-emergency and case and you need to stay in hospital, then you have to go to a private sector hospital. Those from the those union members, they may be they may be able to afford health insurance, and they can also take out insurance. And I think you should speak to the young. I'm now in my 50s. The cost will be very high. The cost is very high. Well, if I am allowed to say after paying 10 years of premium, I don't need to pay any more premium in subsequent years, I will find it happy. But Mr. Chen Kin-po will reject this. I think you really need to spell out what do you want to do. There must be a reason for asking people to take out medical insurance. As for the as for the term, such that one doesn't need to pay premium for subsequent years if one has paid premium for a certain period of time. That is feasible. That's up to the insurance industry to design a product. Say, for example, one can pay premium for up to 65 years old or 70 years old, and then one doesn't need to pay premium any further. And one will still be covered. We'll leave the business arrangement to the industry. Our responsibility is to do more publicity and education so that people understand this. As for the second point, I agree with you as far as the starting point is concerned. But I think the emphasis has to be careful. If the objective is to send people to the private sector, to private sector service, people may not find that palatable. We keep emphasizing the point that this is not for sending people to the private sector. It is to give people a choice. It's not for the government to decide. If you have money, you have take out health insurance. If you have the elective illnesses, it's for you to decide. You can continue to stay in the public sector system, or if you can afford, you can go to the private hospitals. That indirectly helps to divert the patients to the private sector. I think by this approach, people will find it more palatable. That's for your own interests and also for public interest. I have a choice. It's for me to decide whether I make use of public sector service or private sector service. But if you don't have the insurance, you have no choice. If you choose to go to a private hospital, that in fact helps the public. And that is what we are going to do. That's just like travel insurance.
People have high awareness of travel insurance, and and they normally take out travel insurance for going for overseas trips. So we want to work with the industry to enhance the public's confidence in the schemes. So we want to do the same with the VHIS. Well, but the first thing to do is that we want to make sure that the products we offer are good and acceptable and afford basic protection, and then we can do a lot of large-scale publicity. And I will leave it up to the industry itself to come up with more competitive products. And it's just like the travel insurance. People advised to take out various types of insurance for various types of activities on holidays. I would like to follow up on Mr. Yu's suggestion. Now, we normally have $50 billion, and now $30 billion will be taken away. Can you retrieve this $30 billion amount and use it for funding people in the latter years? Then, so that means that the government is encouraging you to take out insurance. You should take out insurance at a young age, and you can help out the government. I think this works. And if we take that approach, then I believe that more young people will take out insurance. Say, if I take an insurance at 30 years old, and when I get old, then there is this $30 billion which can help me out if I can't afford to pay in my late years. So I think that can work, can help divert patients to the private sector. I think that's an approach that should be able to work. P.S. We want to promote the development of the private sector, and at the same time, we will develop both the private and public sectors. And for the public sector, we will continue to make investments. Overall, VHIS is to help the public sector to address the medical needs of the aging population. We are expanding public hospitals systems in Hong Kong. For Kai Tak, the first phase is already costs $10 billion in the first phase, and also in the private sector, we are allocating $10 billion to promote further collaboration between the private and public sectors for elective procedures. We would want them to be done at the private hospitals so that we can shorten the waiting time for public hospitals. For this $50 billion, we would use them in a balanced way. Well, the point made by the member can be considered. We can talk to the insurance sector on how people can be helped in paying a premium during their late years. Well, you mentioned that life insurance products are offering such features. I think this is something first floated by the government. I think not many people objected to saving element in the insurance scheme. Please consider that. Next one, Mr. Chen Kim-po. We support the direction of healthcare insurance reforms. We hope that there will be more transparency in the fees, and the medical inflation can be curbed. And we think the overall direction is right. But as what has the member said, well, members of the public are not very aware of what the proposal is all about. If we make a decision based on that, then that's not going to be good. And on the 1st of March, together with the secretary, I went on to the Radio Hong Kong TV programs. The program lasted for some 2 hours. And actually, before the program was, the people were there had some idea of proposal. The 100 people were there, and all of them said that they supported the overall direction. But then when we asked them whether they would take out insurance, there were some interesting features noted. We had the talk lasting for 2.5 hours, and those who said that they would take out the insurance before the public opinion poll, the rate was 38%, and after the forum, it has dropped to 34%. 27% said half-half, and 36% said half-half after the forum. And those who said that they would not object dropped by 1%, and those who said they don't know anything about the scheme dropped by 1%. So people have more worries after listening to the details of the proposal. The major areas of concern are that if they join the scheme and then they pay up premium for say 5 to 6 years, but then the premium has soared to a level that they could no longer afford the premium, then they will have they're not going to benefit from the scheme. So the government it has no way to control the premium and the doctor's fee. So if the government is not going to do that, well, we will not have any idea of how high the premium will rise. So the crux of the issue is this. Well, overall, we support the direction, but then the protection is widened, and of course, the premium will get higher. The government sets the figure is going to be $3,600. I have come up with this table. I have used the figures from the consultant's report, page 58, and the consultant said clearly that there is a variance of a negative 8% to plus 45%. Using the age of 45, then premium is $4,750. Now, if we talk about 2017, then that will be $6,356. That represents a 6% annual increase. This the top level is 9,216, and for chronically ill is from 19,000 to $27,000. And in 2017 is $9,232. And if the consultant made a mistake, the maximum limit is $13,000. Now, if you are 30 to 34, the fee is $2,200, and 2017 is $29,000, and we're talking about 30 to 34 years ago, and we're talking about 2017. And well, and by 2017 you will become 35 or 37, and then the premium will go even higher. The government has reserved $50 billion for the scheme. But before the end of the consultation, the government said that it will be only $20 billion will stay. And, well, if you talk about a discount of 30%, then that would make a difference too. And if you retire at the age of 65, and if there is a 30% discount, then it will mean a cut or saving of $3,000. So can I be allowed to continue? No, because some other members are lining up to speak. Perhaps a PS can respond to that first. 5 minutes for the members, but then no time limit on the PS. PS, please. We have to make projections for the future, and we are not aware of the actual operation of the market. and we don't know how much more they will charge, say, 5 years or 10 years down the road. So there is a problem with the communication. The reality is this. We know what is committee rating. Well, in some overseas jurisdiction, no matter what age you are in, they are still stay on the same level of premium. But for Hong Kong, it's different. It's age-banded premium. Now, even if we do nothing now, people can't take out insurance when they reach 60 or 70. That's already the situation in the existing market. For 70, 80 years old, the premium may go to $10,000. So it's no different from the present situation. Some people may say that they would be buying insurance policy, but they don't know whether they will cover chemotherapy or procedures in an ambulatory setting. And actually, they are not aware of the exact terms and conditions in their policies. Perhaps they don't know whether there is guaranteed renewal, and perhaps they've been covered for certain period of time, and then they make a claim. Will their policy be renewed? Perhaps they've been paying up a premium for 20 years, and they now get to 50, and they make a claim now, and then they will not be able to get renewal. So for that kind of policy, the premium may be a little bit lower. And Mr. Chen Kin-po talked about a discount of 30% for the premium. And, well, on what basis is that discount calculated? Is it the premium charged by the insurer? And we never know what the situation will be. For the government, it's difficult to ask us to shoulder the risk of paying for the 30% discount. Members of the public do not like a mandatory system, and some of them don't want a voluntary contributory system. Second round, Dr. Kwokaki. Chairman, I have 2 questions for the PS. The key to the issue is what will be the injection from the government. And, well, when people reach 65, normally they can't afford to pay minimum. And this is exactly the time they need insurance most. Maybe they start paying up premium starting from 20 to 30. And those who are in the aged 65 above use most public hospital services. And actually, the ratio between those aged 65 to those below 65 is 8:1. And those aged 65 have a high propensity to be included in the high-risk pool. Well, let me correct you. They will not be in the high-risk pool. If they have taken out insurance at an early age, they will never be admitted into the high-risk pool. If they have paid premium for 40 years and when they get to 65 or above, they will have to pay a premium of $11,000. I don't know whether Mr. Chen Kin-po's figures are correct. I don't have a great trust in the insurance sector. So we are talking about $11,500. And the colleagues have made 2 suggestions. And if a person gets to 65 years old, he can't afford to pay the premium, is there any subsidy for him? That can encourage people to take co-insurance if you go down that route. Second, and people with a 200% risk will be admitted to the high-risk pool. Let's do it in a fairer way. Can we inject the $50 billion into the high-risk pool? And then you can draw a line further down. Well, where can the line be drawn? Can you tell us? So many more people can, say, get into the high-risk pool, and that will be a fairer approach.
Do you have the number? Say how many can the $50 billion protect, and for how many years? And how many people get into that safety net? You better clarify certain concepts. There are two things. Age is another thing. We have dealt with that. We're talking about the risk ratio. Mr. Kwok, what do you mean 10 years, 20 years? There are two things, Mr. Chairman. Assuming that he puts $50 billion into the pool, say the high-risk pool can sustain for 10 years, 20 years, or 30 years. Say if it is 200% loading, then it will be for 40 years. No, 20 years. $4.3 billion. If it is 100% loading, say $50 billion to be spent for 20 years or 30 years or 40 years. How far down do you can you reduce the line or threshold? Not 2 times or 3 times, or whether it's 0.5 times. The only thing you can reduce the number, you can reduce the premium increase is to put more people into the high-risk pool. Now, when he wants to take out the premium, is already when he wants to take out insurance cover, the premium is not so low. Now the question is, although it is a high-risk pool, the premium is still very high. How can he take out insurance? How can you reduce the premium? Now, you raised the point on how the age varies. It's about the age 60. Now it's about the risk ratio. You adjust the definition of the high-risk pool. Now the risk is 3 times is in the high-risk pool. Now if you reduce the risk, say, to 1.5 times, you are in the high-risk pool, what will be the cost? Now, if you set a higher threshold, then there will be less people can use the high-risk pool, and only the relatively well-off retirees will use the high-risk pool. Now, can you reduce the threshold? Even if he doesn't pay, he cannot afford the premium, you help him to now if he contributes for 40 years, then will you help see him out for the rest? Will you look after him for the rest of his life after he paid 40 years of premium? They only pay the premium to the insurance companies, not the government. Even if you are in the high-risk pool, it doesn't mean that you don't need. It doesn't mean that you don't need to pay a higher premium. I want Mr. Kwok to look at this. Age 60 to 65, high-risk pool 9,232. He has to pay about $27,000. With the increase in age, if premium keeps increasing, you will have to times it by several. The factor may be bigger than 3. Mr. Chen, can you also provide this copy to the Secretariat? Though I don't trust him, he has provided a more detailed calculation. He is more honest than the government. By the age of 50, one has to pay more than $30,000 if one is in the high-risk pool. Yes, please give a copy to the government for reference. See if the government has any, if the administration has anything to respond. It doesn't mean that if you are in a high-risk pool, there will be no increase in premium. I think the premium increase will be even bigger because of time constraint. I say that without the $50 billion to attract people, then young people, healthy people will not take out insurance cover. And the scheme, therefore, is not sustainable. Now, if one has paid premium for many years, one cannot afford any more because the premium is too high. And that is the time he needs insurance most. At age 45 to 49, you need to pay $6,000 to $9,000 in terms of premium. For those who can only afford about $3,000, they will go to the public sector hospital. As for portability, there are practical difficulties, and I have some proposals for the administration which support the general direction. But you will create a situation in which those who have paid insurance will be disappointed because they don't have any more money to pay premiums subsequently. I think the most important is for those who have retired. After 60, I will have to pay insurance out of my own pockets. I may have. You really need to say have a scheme that can be sustainable. Now we'll talk to the policy secretary, and we have a counter proposal for the administration. Nobody wants to destroy his industry. If you don't pay the $50 billion and you force us to sell expensive products, then you're just destroying the industry. Those who are young and healthy will only go to the public sector service, and only those who are of ill health, they will take out insurance cover, and that will only lead to increase in premium. And some may have to pay $50,000 in terms of premium. We hope that the administration will leave it to the market. Please don't play God to control the market. You can't control the market. You have no commitment. If you set up an insurance company, the government runs the company, the government will not increase premium by 5% or 10%. I welcome that you do your thing and then we do our thing, and let people have a choice. If you say that premium increase in the future will not be big, this is just empty word. There are many reasons for premium increase. Say treatment methods may be very expensive, they cost a lot, and people don't know about future inflation rate. There is a need to control medical inflation, and you should encourage more competition among private sector hospitals. It's not just to control the insurance industry. As operators, we're afraid that this is not sustainable. And that's our greatest worry, and you will destroy the medical insurance industry. We hope the administration can face up to this issue squarely. Mr. Yun, I've said it many times before. I'm a bit confused here. As for young people, they think insurance cover is not enough, and therefore they don't take out insurance. What about the present insurance? Why young people don't buy it? Now, if you say that under the new proposed scheme, people cannot afford it after 60-year-old, then why people buy it? Now it is cheap when they buy it when it's young, when they are young, But after 60 years old, they cannot afford the premium. I'm really bewildered by the argument. I don't understand the point made by Mr. Chen. Why young people buy medical insurance now? The reason is it's cheap now. I still have a few seconds. You don't have adequate protection. And when he's young, how can he have adequate protection after after he becomes 60? And how can he afford that after the age of 60? If it is under the current condition. Under Table 58, if you are 35 to 39, you don't need to pay $3,600. $3,600 is an average number. You say many people are paying less than $3,000. Is it the average age or is it on the same terms? Say if the average is 2,500, you say there are many that are below 300. I say my number is an average number. That's why I'm not clear about what the point made by Mr. Chen. As for playing God, I have to respond to that. It's not that Hong Kong is very unique in doing this. In major insurance markets, there are such regulations. It's hard to find a place which doesn't have similar basic requirements towards insurance products. We are not unique. We do not deliberately regulate the insurance industry. In fact, our proposal is in response to the regulatory arrangements in other parts of the world. Yes, please follow. I want to ask for a third round. I only have a few seconds left in the second round. Okay, no one is queuing up, so you can go ahead. As for young people, they find it not affordable. That's a fact. I don't know why you don't know. When we consult young people, they say they can't afford it. This is a fact. What is incentive? Tax incentive is not great enough. That is not subsidy. And taking out an insurance is not sustainable. Now we get the insurance company, we get 1.8 million. For those, half of them are paying less than $3,000. Very few of them are young people. They belong to the common age group. As for those, the points which the PS doesn't understand, I really don't know why it doesn't understand, because it's very simple. The numbers are not calculated by me. Well, I stop here. I just hope that when we meet and talk to the policy secretary, we will make a counter proposal to the administration. We do it from the perspective of the operator. We show you the possible difficulties under your plan. Now, those who have taken out insurance should be able to use it. That's the objective. How can you prevent the bubble from bursting, the insurance bubble from bursting? This is also our objective. Now, you seem to paint a rosy picture, but in fact, your proposal is full of holes. We won't stand in your way. We want to make it possible. The most important thing is to control medical inflation. Now the claim rate is about 74%. Now $100, $26 for cost, administrative costs, and also profit and other costs. You also need to consider group insurance. A company does group insurance and individual insurance. They cross-subsidize each other. You cannot exclude one from the other. Without individual insurance, group insurance premium will increase, and vice versa. As for average premium, everybody knows what a premium is, what an average is. For those who take out insurance, they are not in the 20s or 30s. You're talking about those about 40. They have a stable family, they have children. They're afraid that there can be unexpected expenses. You have to look at the age group. According to that table, for those about 40, your in 2013 is 3300, and in 2017 is 4415. That's according to your consultant, and we don't know if that's correct or not. Say, existing conditions have to be carried, which is not done at present in Hong Kong. There must be continued cover. There must be guarantee renewal. That is not our current practice. So it is. There is huge cost implications, and that will increase insurance premium. If you allow us to increase premium, we dare not do so because we're worried.
So we are worried that the bubble will burst, so to speak. As what some medical professionals said, the bubble is going to burst because there are moral hazards, and you can't control doctors, how doctors charge our fee. And sometimes the doctor may say that when you look at the policy, then your limit is $100,000, and I'll charge you $90,000. And if your policy is $50,000, then I will charge you $40,000. So if there is certain limits on the fees, then that would be better. Well, I have to rush off to another engagement. Dr. Kwakaki. I won't totally agree with the insurance sector's views. I am looking at it from the perspective of the members of the public. I'm worried that once a member of the public joins the scheme, he won't be able to get out. He may want to continue with his policy and get the protection. But then if you look at the table, well, in fact, the DH has got statistics. For those aged over 50, those who are chronically ill, it takes up 20% of the population, and the number rises after the age of 60 and above. And there will be a loading on the premium. According to Mr. Chan, well, the number will not be 10282. Well, it will rise to about $15,000. It will be $15,000 to $20,000. If they start taking out insurance at 25, and if they get to 50, their median salary is only $12,000 per month. And how can you ask a person on a salary of $12,000 to pay a premium of $2,000 per month for his healthcare insurance? Well, at 50, he may start using the insurance. Perhaps he would have joined the high-risk pool at the outset. And if the premium gets to $10,000, $20,000, what should he do? So can you consider that if he has paid up a premium for a certain period, and if he retires and unfortunately he develops diseases and he can't afford the premium, can there be other insurance policy to provide cover for him? For those aged 65, they normally can't afford several dozen $1,000 for the premium. So can you do something to cover him on the days when he can't afford the premium? When the time comes and they have to use insurance, they can't afford the premium. And there is no guarantee for that the premium that he has paid can be used. and perhaps he starts paying premium in his 20s and 30s, and when by the time he gets to 50, he has to pay over $10,000. You may put a limit to the premium, but not the loading. Is that right? Can I try to explain? Assuming that an ordinary member of the public takes out insurance at 20 or 30, paying a premium of $3,000, and he pays a premium up to 50, and then he starts developing diseases, and he is a high-risk person. According to our recommendations, no matter what diseases he gets, he would be paying the proposed premium. So that's what we meant by guaranteed renewal. If he hasn't taken out an insurance policy at all along, then that would be a different scenario. I'm worried. And I agree with Mr. Chan Kim-po. The premium is low because the utilization rate now is low. And you have been criticizing that policyholders don't normally make use of their policies or their insurance to insurance. So in the future, the utilization rate must be higher. And this group of people gets guaranteed renewal, and they definitely will use more private hospital services. So it means the premium will continue to rise, and also at a higher increase rate than in the past. Many more people get into this scheme, and there is no restriction on the diseases or illnesses when they make a claim. So the utilization rate is bound to get higher, but the insurance sector will definitely shift the burden to the consumers. And there is no way the government will control the premium, right? So the premium will will soar, is that right? Mr. Chen made a valid point. Is Mr. Chen talking about group insurance policy? And he's trying to, well, he was mixing things up. For group insurance, the claim rate is around 80%, or $80 out of $100. For individual insurance, $60 out of $100. Why the higher figure for the group insurance? Because the requirements are there. Well, for group insurance, normally all kinds of diseases are covered. And also, there is guaranteed renewal. The insurance company must cover everyone. And one insurance policy covers everyone. So is this what we are proposing now? So the claims ratio is relatively higher, and the expense loading ratio is lower. So the claims ratio in the past several years for individual insurance has risen from 57% to 69%. And the gap between the two types of insurance has narrowed. One possibility is that some major insurers have launched products similar to what we propose. So they've got many more customers, and more claims have been lodged. So because there are more claims, the expense loading ratio has been reduced. How come that the premium has not risen? And that's because they've got more customers, because members of the public are aware of the benefits of insurance. And the result is that the claims ratio has increased from 57% to over 60% in the past few years. So the situation is different from group insurance. One policy covers everyone, every type of disease. I can't say for sure that if we roll out the VHIS, the insurance will not raise a premium. But from what we have observed from the experience of group insurance, we are seeing that things are improving. Well, take a look, an objective look at the group insurance policies. They're very similar to what we are proposing. The insurance sector may take a different view. I hope that I have answered your question. And that is why we are confident that there will not be drastic increases in premiums after our proposal gets implemented. We tried to be empirical. I retrieved some information from the website today, and I looked at the policies of some major insurers. The only difference is guaranteed acceptance. Some policies already offer guaranteed renewal, cover day surgeries. They offer $50,000, while our proposal is $15,000, and they also cover MRI for outpatients and standardizing policies and terms. And the premium is just around $3,000. Let me provide you with more information, and then I'll follow up with a question. I am in contact with peers, and more insurance companies offering products mentioned by you, but then the coverage is not that great. And some doctors are telling me that the cases or the people who have taken out the products you mentioned are actually going back to the public hospital system. And sometimes they get quotations from the insurance companies. Well, their coverage is only around 50 to 60%. So once they heard that is only going to be 50 to 60%, they're asking the doctors to write a referral letter referring them back to the public hospital. There is this major business group employing over 10,000 people. In the past, the company provided for their own insurance coverage, and 80 to 90% received the treatment. But then the co-insurance ratio gets higher and higher, and people are finding that they are not fully covered. And well, for 30 to 40% of the patients, the doctors are writing out referral letters, referring them to the HA. And people get back to the public hospital system because they're not fully covered by their insurance policies. You haven't answered my question about the fallback position. Now, once a person has retired, and if he can't afford premium, and actually everyone knows that people aged 65 need medical services most. Is there any way that the government can help these people? The claims ratio for group insurance is much higher than individual insurance. And well, many people are referred back to the HA. Well, that's because the coverage is not adequate. So that's why we set out the minimum requirements, offering basic protection. For example, surgery fee, $57,000. Well, generally speaking, well, the doctors have this idea of $57,000, and then they would try to work towards that amount. Well, once we mentioned about DRG packaged prices, and that is difficult. Well, it's impossible for the government to adopt that approach. The difficulty with group insurance is that some insurance companies are offering low premium and low coverage, then that is not good enough. And so we come up with a $57,000 as the amount to be proposed. As to the question of fallback, how do we deal with people who have paid a premium up to the age of 60? Well, it will be difficult for the government to deal with that because policies may vary from one to another.
They fulfill the 12 requirements, but they can be better. This is give me the most basic 12 requirements, 12 conditions, no more, no less, standardized package at the age 65. For those above age 65, few can still pay the premium. Let's be realistic. Don't cheat. Now we have to look into that. I cannot regulate the premium. And just like I don't want to regulate the charge by doctors. And that leads to the issue of whether the charge is reasonable or the fee is unreasonable. I expect that they will make arrangements in the future. I mean, in fact, many employers are paying the group insurance, and after retirement, you find it difficult to take out medical insurance because after that, you may have cardiac illnesses or diabetes. Now, after retirement, it's hoped that the company providing the group insurance will also provide insurance for those above age 65 who retire. Well, if our system is good, then people will make such a demand, and then the companies, the insurance companies may provide the products. Now, one is that you make contribution until age 60, and then the insurance protection is until 80. This is just like life insurance. If you contribute until 60, then you will be given protection until 99. I think that can be considered. I understand your point. Your point is right. After you've paid premium up to 65, and then you cannot afford that, then you have to go back to the hospital authority. And those who are in their 60s, there is the issue. I think there is another government official who is waiting for the next item. I thought that our meeting will continue. If that is an outstanding item, we can discuss at the next meeting. I've noticed that the HA has a representative here. Do you have something to inform us and you want to move ahead? Well, I know that the chairman is interested in the numbers in relation to the HA. Is the HA going to report to us something, and then after that they will go ahead and deal with that? No, there is no specific item. All right, we deal with manpower at the next meeting. Anything to follow up, Dr. Kwok? Well, we have raised quite a number of points today, and there are certain responses to questions asked at previous meetings, and Mr. Chen Kin-po has not followed them up. Now, after fulfilling the minimum requirements, what will be the additional premium? The paper has explained that. Mr. Chen Kin-po is worried that because of this minimum requirements, premium will become very high, and his view that the administration has underestimated the implications of the minimum requirements on premium. Now, you say the increase is about 9%, but the consultant says the variation is from -8 to +45%. You have not taken into account inflation. Mr. Chen Kin-po is worried that the scheme will burst. The scheme will not be sustainable. I have looked at your explanation. Now, after the minimum requirements are fulfilled, you've added pre-existing illness, premium will only increase by 5%. Why is it so? According to your explanation, I think that's not our question. I've looked at your explanation. Now you will cover pre-existing condition, and the premium is only increased by 5% because of the following. Out of 100 insured, only 10 will have pre-existing conditions. Their premium will be increased by 100%. And then the 100% is shared by 100% of the 10 people will be shared by 100 people, and therefore, on average, premium is only increased by 5%. Is my understanding correct? Our original question was not about it. Our question was, this, as for this particular person or the insured, if he has a pre-existing condition, if he his cost is not shared by the overall increase of premium of the group, if he has to pay for that pre-existing condition in terms of premium, how much will be the increase of the premium? Only the insurance companies have the numbers. The insurance companies do not take on or do not accept those with pre-existing conditions because they know the additional cost. It is definitely not 5%. It will be very expensive. I just want to know that number. That's the loading. That's the loading factor. When Mr. Chen Kin-po heard it, he was shocked because that was the increase of the overall premium by 5%, not for that particular person. I'm not talking about that kind of that group of insured persons. At the end of the day, we need to look at the data. Concerning pre-existing conditions, how will that increase the premium? It's for that group of persons. It's not that other normal persons will share out the cost. To share out the cost of the pre-existing conditions. It's not that. We have to look for that. Under our proposal, say, if I have a pre-existing condition, I go to an insurance company, then the company may reject me, may increase loading by 100% or 200% or maximum 300%. I will pay 300%. Our proposal is this. In the future, if I have a pre-existing condition, I take an insurance cover. The company has to accept me, and no loading is allowed to be increased. No loading is allowed. So other people will have to pay 5% more in order to share out their loading. No, that's not the case. You allow them to increase loading by 200%. And that is the existing practice. If it is more than 200% loading, they will reject it. The practice is that when it's more than 200% loading, then they don't accept. That's why we draw a line at 200%. Mr. Yuan, I want to know what is the actual increase in cost. I just want to assess whether your proposal is feasible. When there is the diabetic who is rejected by a insurance company, the risk to the insurance company can be accepted, but there may be many customers and therefore the company rejects the patient. You're right, exactly, Mr. Chairman. I want to know, for this group of patients, what exactly is the increase in cost in order to understand whether your proposal is feasible. Your example is that there are 100 insured persons. 10 have pre-existing conditions. The premium will be from $3,000 to $6,000, and the cost is shared, therefore, by the other 100 people. This is just an assumption. You assume 10 out of 100 have pre-existing conditions. Is it in our population? This is a condition. A pre-existing condition can be diabetes. It can be serious diabetes. It can be mild diabetes, hypertension. Everybody, nearly everybody is. What exactly is the risk? It is unlike your example. It's not just 100%. I want the actual data. I think the administration or the insurance companies have such data. What is the percentage of people in the population who has pre-existing conditions? And I also want to know the cost, actual cost. You have the historical data. Say if the cost is 300% more. If you have the figure, then the insurance company will take on that. And if they cannot take on that, the excess will be taken up by the high-risk pool. The increase in premium, if the premium increases by 10 times, then your high-risk pool is bound to fail. I want to know, after adding 12 minimum requirements, premium will be increased. By how many percent? This is not about the overall increase in premium. It's about that group of people. The increase in premium for that group of people in order to assess whether your scheme is sustainable or not. Mr. Chen has made this point repeatedly. There will be medical inflation. There will be different kinds of inflation. Your table has not included that. Since he's so worried, can you show us the numbers? It's impossible, Mr. Chairman. The insurance market has to face medical inflation, even if we don't have VHIS. With like comparison, there is an increase of 9%. Now you can assess manpower until 2040. Now, Dr. Leung, tell me, how much will your medical fees increase by 2040? That is after 25 years old. After 25 years, if you ask me to make an estimate, I look at the numbers 25 years ago and in comparison with that today, and then I can give you a guess. Prediction is based on historical data. You can use a standard deviation or standard proportion to forecast what will happen after 25 years. Members say that the member says that the bubble will burst. You can make a comparison. your VHIS in comparison with other scheme. You say even if you don't do anything, the bubble will burst. I don't say that. You face inflation, you face the same rate of inflation. If we don't launch the government scheme, we just let nature to run its course, it will be the same. Show us the calculations. With government intervention, without government intervention, what are the differences? Let us show the differences. With government intervention or no government intervention. If the difference is only 9%, people can make a choice.
So even if the members don't support your proposal, then that's definitely going to happen. And then if we support your proposal, then, well, there is just a few percentage points possibility that will happen. So anyway, I'll spend some time to communicate with the clerk to see whether you can provide us with further details later. So for the consultation document, we hope that the consultation period can be extended because our attention has been drawn to other aspects. We will continue to hold meetings, and I believe that you will still listen to our views despite the consultation will end very soon. A minor point, Chairman. I welcome the extension of the consultation period. If that period is not extended, when will the government come back to us? Will you let us know the consultation results? Our subcommittee will continue holding meetings. I want to have the government's timetable. What's the government's timetable? Well, the consultation will end on Monday. When will you come back? We will spend, say, 1 to 2 months to collate the views. I would like to put a marker here. As what Mr. Chen said, we will further talk to the insurance sector, and we'll see whether they will raise any special issues. So it depends on whether changes are warranted when we discuss with the sector. So we aim to come back within 1 to 2 months' time, even if we haven't completed our work. Permanent Secretary? Well, the public's views on how the $50 billion will be used is constantly changing. So I will ask the clerk to schedule subsequent meetings with members and the government. We will talk further to the government. So we need to talk about the manpower planning. They have to come back to discuss that item. That's not covered today. I have to explain, Chairman. We will increase the number of university places and that are subject to the UGC procedures. Pending that, we can't give you concrete figures. We have to wait till the UGC has spoken to the various universities. I think it would be better if you can come back before they have their discussions. You can talk about the principles, not the concrete figures. Perhaps we can schedule a meeting after Easter to discuss manpower planning. And we'll see what directions you will take. All right? Thank you very much.